So I like your idea. We're going to start globally, and then we're going to get more and more focused. And, there may be a kernel of a new idea between us. Yeah. So, we are really in an historic time. Yes, we have other pandemics to look back on and learn from. What I found interesting, actually, historically, was they knew back in 1918 that wearing a mask was a good idea. And it's, obvious on its face. And when we first were told by the CDC that masks were not necessary and that kind of thing, it just went against my instincts. So, certainly our family and our practice has worn masks very early on in this pandemic. So we in Georgia are really the first in the nation to reopen our economy. And, we've been given some guidelines by the federal agencies. We're looking to see a reduction over 2 weeks of new cases. We're looking to have the infrastructure in place, hospital capacity, testing, et cetera. But really, we're doing a lot more opening without sort of the respect for some of the systems that they want in place. So it's a balance between the health of the population and really an economic tragedy for so many. One of the things that I think became very clear in this pandemic when we were asked to stay at home and work from home, there really is a schism. There's a separation between who can actually do that and who can't. And many of the lowest paid workers in our economy are those that have to put their life at risk because they have jobs that require that they're out there. Truck drivers and delivery and people that are really doing jobs that can't be done remotely. And then, of course, there's the healthcare workers, everyone in the healthcare environment, from the people that run the hospitals to the people that maintain the hospitals to the people that work in the hospitals daily. It's really shined a bright light on really the way that the economy has sort of separated. And I understand the pressures about coming back to work and getting back to it, if you would, because those who, like I said, can afford it least financially are often the ones who are carrying the brunt of this financially as well. I know a lot of workers in the food industry, in the beauty industry, which in some sense we're an extension of, that really have to step away. There's no work to be had, and they're not able to survive on their savings. And I feel the pressure for them. We'll get into what our practice has done specifically, but where I'm going is that the flattening of the curve is really about not overwhelming the healthcare system. It's really not about preventing everyone from getting the disease. In fact, really, the way we're going to get out of this, I think, is we're ultimately going to have to get exposed. And a lot of us are going to have to be exposed to COVID and convert to, COVID positive. What we're learning now from the data from New York is about 20% of the population in Manhattan is testing positive for having had COVID. So it's really interesting because most of those people were completely asymptomatic. Now, again, every death is a tragedy. Every death is a family member and a person. And I don't mean at all to belittle that. But the fact is that we look statistically, what we're learning from New York is that the mortality of this virus may be on the order of more like 0.5% rather than 1 or 2%. And the other thing we're learning is that there are comorbid conditions, cardiac, hypertension, high cholesterol, other underlying medical problems, obesity, diabetes. So there really are two types of patients. There's the high-risk patient, and then there's the low-risk patient. The high-risk patient is really someone that suffers from diseases that are ubiquitous in the United States: obesity, hypertension, diabetes. These patients are at higher risk for severe illness and death. And rather than shelter everyone, we may end up coming to a point where those who are better able to survive the illness, if they were to get sick, are going to really be asked to return to a more open community. And those at higher risk may be ones that want to be more shelter in place, stay at home to the best of their ability. And I think that's the way we're going to have to open up, because at the vaccine will not be available for a year and a half or longer. The quickest we've ever developed a vaccine is 4 years, and that was for the mumps in the 1960s. Technology is advancing. We're doing things more rapidly. In fact, I was seeing an article today that said the rate of scientific advancement is becoming so quick that we're really, in some ways, suspending our basic scientific method, the sort of orderly way that we develop new medicines and new treatments is being suspended because we're in this crisis and everything's being pushed so rapidly. So I think if we really think about it, we can't stay at home forever. And we have to recognize that there are some high-risk patients that may need to do more protection, but there are lots of people who are healthy who may have to say, you know what, I'm probably going to get this disease. I have to return to a normal lifestyle. So it's a balance. And that's what I think the governors are trying to find, that balance based on their community. I don't think every community is the same. I don't think necessarily that Georgia is at the point just yet where we should be aggressively opening things that, are pretty high risk, such as restaurants, such as tattoo parlors. I mean, are these really vital? Health clubs. I understand why everyone wants to get back to the health club. But on the flip side, doesn't it sort of make sense that that's a high risk environment? But again, generally healthier. Generally are people that would tolerate being sick with COVID. So perhaps it's not so crazy. We're not going to know. We're just going to have to sort of gather data, and we're the tip of the spear here in Georgia. So with that, understanding that we haven't developed new treatments, testing is not widespread, but we can gather some important data. We have enough tests now where we can do some sampling. The CDC is very good at this when it comes to flu sampling and other disease outbreaks. They'll take a sample of the population and do statistical modeling based on that. So I think we're really at the point where there are enough tests to do some statistical sampling around the country. And that's something that should be done. I think that should be done here in Georgia before we just open up. I think we should have a sense as to how many people are actually infected, especially if we're going to be a leading state and others are going to look towards us. How can they interpret their state's data without knowing ours? And without data to start with, how can we really interpret our own? So it's really, I think, a missed opportunity that we're not doing that. But having said that, there are things that we are doing that are risky. There are things that we're doing that perhaps are premature, but this is what the government is somewhat pushing. And I can't say that I don't understand it, but as a healthcare provider, I err on the side of safety and wellness. And that's sort of the approach that we're taking as a practice that's been asked to reopen, to get back to elective surgery, to get back to dealing with not life and death, not critical stuff. It's not that aesthetics and elective stuff is not important. It really is. It makes us feel good. And truthfully, I always tell patients, I'm not treating just your face. I'm treating your soul. I'm treating your sense of self-confidence. I'm treating the inner you. If all I did was provide a better look, it would be a rather superficial intervention, but it's that emotional uplift that I think we all enjoy when we look good, when we feel happy about our appearance, that really translates into so many other aspects of our life. And really, at a time of crisis, I think every opportunity to elevate people emotionally should be really valued. And that's really one of the things that I'm looking forward to. I will share with you a funny story. So every year we celebrate our anniversary. We have a big blowout event in June. It's attended by hundreds of patients, and it's just a lot of fun. And last year, like every year in June, we had this event, and we sent email messaging to our patients to announce this. And for reasons that no one can even explain to me, that same message from last year was sent out again just this past week. And a lot of our patients were calling expecting that we would be having a June event. Of course, we're not. We're not holding a June event. We're going to do some virtual events, but nothing in person. But what it showed us was the overwhelming response of patients to want to get out of their house, get back to normal, start focusing on things that are not just COVID related and not just, about survival. So there's this pent up desire to return to normal. I think we all feel it. But having said that, we're going to have to define what a new normal is, because we're going to also have to respect what I said earlier, which is there are some high risk patients, and they may be some of the folks that are coming to my practice, some of these older people with comorbid conditions. So, we're setting in motion really a new definition of what it means to practice in the post-COVID environment. Doing all the normal things, doing a questionnaire, taking temperatures of staff and patients, separating patients with larger time slots so that there's less overlap or no overlap, not having patients wait in the waiting room, wait in their car before their appointment to come in, being extra sanitary, everyone wearing masks and gloves and protection, and all the things that we're taught and we're all now aware of. But having said that, as we open up the economy, there's going to be some increases in cases. I think it's going to change the way people are doing business in general. I have a few friends that travel a lot for business, and they said that probably about 20% of their travel right off the bat is going to stop. They'll do virtual, conferences and so on. So it might prompt you to do some more work from home.
Well, you know what? I am busier now with time-sensitive projects than I've been in ages, because one thing I'm very involved with, and my writings and my podcasts have all been tapping into leading thinkers of the world, and simultaneously I've always been involved with this Nantucket Book Festival, which is a really, really great thing. And suddenly we had to cancel that festival, and I'm thinking there was an opportunity here to do something that we've never even imagined in the physical festival, which is I can sit here, I can in 2 seconds with a Zoom link come into the homes of these authors, and they don't have to worry about traveling and getting stuck in a storm and all that stuff. And then, so this is already started, we're going live in a week, so I'll send you the first links. But then what happens is we can cross-fertilize ideas, and it's like I have one author, and then I have another author who said, boy, I'd love to speak to that author. And boom, they're together. So now we have these great minds. It's almost like Dick Cavett had a show, many years ago, even sort of before my time, but he was known for bringing people from different disciplines together. Now, there's no reason that can't be done in person too. So my point is, we might be able to come up with new ways of doing things that then we can carry over from the virtual world back into our physical world.
Yeah.
So I think there's, if we can just get out of this before so many people really are destroyed or, damaged for the long term, which is already happening. But let me come back to you, because here's what I think. I guess what motivated me to call you too is you right now even have a sort of a remarkable ability to balance, my son John and I have been talking about this for days. When is the right time to start opening up? How do you open up? So, he's been more along the lines of what you're saying, which is well, maybe there's an opportunity here. We just have to do it right, but we can't, obviously, nobody's saying we can sit around forever. And New York's different from Georgia. But I just sent him 2 articles, which I know he's going to be interested in, which is the Wall Street Journal opinion page today, which addressed Kemp in the opening, and also Brett Stevens of the New York Times, who's their conservative columnist. And you're sort of striking a balance between both of them because you're getting into more detail than these 2 editorials did in terms of how do you assess what are the right protocol for a given time. And I'm really struck by this idea that viewing Georgia as a potential leader, leading the way in terms of how we proceed is very empowering. But the reason I contacted you is I think there's an opportunity for you to say, okay, you have just laid out, without even taking a breath, but without rushing, all the calculations we have to make. And again, just a little thing for you to think about. So the author I was interviewing yesterday is a guy named David Rode. David Rode won a Pulitzer Prize for his reporting in Bosnia. When we had satellite photos during the Bosnia War that indicated there were mass graves, this was the Srebrenica massacre, David Rode was on the ground. He figured out a way to get to that spot. He uncovered the bones and the canes, and also he won his Pulitzer. He was later arrested by the Serbs and then released 10 days later. Now, fast forward to 2009, 11 years ago, he was in Afghanistan, also risking his life for a different cause. He was writing a book on Afghanistan, and he wanted to get to a member of the Taliban who was going to be a character in his book. And he took what he felt were reasonable precautions. The Taliban had already been contacted safely. They kidnapped him. They set him up. They kidnapped him. He was held hostage with his translator for 7 months and then escaped. If he hadn't escaped, we don't know what would have happened. As he looks back on that, he said, he gives young authors, young journalists advice. He said, you've got to weigh the risks with the rewards. He said, I would have taken that risk again with Bosnia, even if it had meant longer captivity, because we were uncovering a war crime. The impact of that was so huge. But it was my pure competitiveness in Afghanistan. That wouldn't have made a story. It would have made for a better book, but it wouldn't have changed the world in the way that Bosnia's story did. That was a stupid risk, and I forever regret putting my family through it. You're doing this same assessment now, trying to, what's the bang for the buck?
So sometimes when we're training residents, we get into a sticky situation. There might be a lot of bleeding around critical structures, and the anxiety in the operating room can go up. But I always reminded them, I said, listen, you're not a pilot, you're a surgeon. When pilots get into a sticky situation, their life is on the line. And in surgery, you're okay. So just take a deep breath, gather yourself, and address, because you're personally, physically not in danger. And that is one level below what a pilot must experience. Like you were telling me about the author that won the Pulitzer Prize and put his life in danger, that's a different level of commitment. But today, or even back in the day with HIV, with no treatments. So getting AIDS then was a death sentence. Doctors, nurses, all the frontline workers in the healthcare environment are putting their lives at risk. And like I said earlier, there are healthier groups that are much less likely to die from this. But a lot of doctors work a lot. They may not take care of themselves as much as they should. They have long hours. A lot of them have a lot of stress. They don't sleep well. They don't eat well because they're working a lot. So their immune system may not be up to the task. And, we've lost a number of healthcare workers. I know that the number I heard was 9,000 or so have gotten sick from COVID. But again, a small percentage have died. But there was a very famous neurosurgeon in New York that passed away, a pediatric neurosurgeon. And when you lose someone of that caliber who's done so much, it has a ripple effect because he touches so many lives. But anyway,
You know,
I think there is.
but now let me just take you even a further step back. Tell me the story. You graduated from what medical school?
Yeah.
With what specialty, or not a specialty at that point? Take me from there to was it your residency where the AIDS crisis was starting to become in full bloom? I'm interested in hearing that.
So I went to NYU Medical School, and the reason that's important is one of our main training hospitals is Bellevue, and Bellevue Hospital is the big city hospital in New York City, and was ground zero for the AIDS crisis when it first developed in the early and mid 80s. And I was there from 85 to 89. And I will tell you, when I was doing my training on the wards in medicine, one of our jobs as medical students was drawing blood. And it was not at all standard practice to wear gloves when you drew blood. And I will share with you that I did, and I was pretty compulsive about it. It just seemed like a good idea. And I took a lot of flack for that. There was a lot of sort of man up kind of attitude, and why are you doing that? And sort of making me feel less than. But in hindsight, could anyone today imagine drawing blood or dealing with blood products without wearing gloves? It wouldn't cross our minds. So, I feel like COVID-19 is presenting similar challenges. And I'm happy to say that, when I go to the supermarket now, most people are wearing masks. Not everyone, but most. And it's a little bit of a different calculation. There's an ethical component. You're not just putting yourself at risk. Since we have silent carriers, you may be a carrier and not know it, and you may be spreading the disease to others who are less well than you and less able to protect themselves. So I think we all have to sort of move into a new phase, just like with HIV, when we had proper sort of techniques in the operating room where we would put sharp objects down, we wouldn't hand them back to the nurse, right? So we modified our behavior. We double gloved. We wore gloves whenever dealing with human blood or excrement or any other bodily fluid. And I think with COVID, we're as a society recognizing we have to change our behavior. I think the handshake is out. The wave is just fine. And that may not be a bad thing, because we do live in a germ-infested world. And if you look over the last 20 years, we've had every 10 years significant outbreaks of corona-like pandemic or corona-like epidemics. They didn't become pandemics. They weren't as contagious, or they were much more lethal. But, we have lived through many as a society, as a human race. And I think that's going to get more and more regular as global warming becomes part of the world, that we have to accept. We're definitely doing farming practices that are not healthy. These large farms where these animals are stressed are putting animals at risk for disease, and those diseases can then transmit to humans. I just found out that 2 cats developed COVID, house cats. So it's going both ways, animals to humans, humans to animals. So I think this is changing the way we approach it, but I just want to recognize the fact that we can get through this, and we will get through this as a society. The question is, how much long-lasting damage will it create? How many people will lose their lives, and how much will people lose their livelihood? Let's not forget that if you lose your livelihood, you lose your purpose, you lose your ability to provide for your families. You have increased depression, you have increased gun violence, you have increased domestic violence, you have increased suicide, you have increased, risk. All of these things are health risks, and you can't view anything in isolation. So there's no perfect solution. There's not all good. We unfortunately are faced with bad choices. Either one provides bad choices. So the epidemiologists talk about reducing the negative consequences. I forget the exact term that they use, but basically it's the best of the worst choices. And that's what the government is trying to balance right now. And I can really empathize with that. I'm a provider for my family. I'm a provider of healthcare services. I run a business. I have a lot of people that rely on me for their livelihood. It's a ripple effect. And then we have the lost benefit of what we provide to our patients. So it's a very challenging time. I mean, you and I we're living through this historic moment and trying to figure it out with no roadmap. I think it's sort of like being a parent, right? I mean, you get the kids you get, and there's no roadmap for how to raise them. Of course, there's generations before us that we can look towards, and perhaps there's some of that with other pandemics and other epidemics, but we are definitely learning a lot about this disease that we didn't know even 2 weeks ago. I read an article about how it increases clotting in some individuals, and that's what's killing some of these young, healthy people. It disrupts our body's ability to have blood flowing, so we clot too easily, we get strokes. Ebola was the complete opposite. People were bleeding out. They couldn't clot enough. So these viruses in some way are interrupting our normal clotting and coagulation systems, and we don't really understand how yet. So there's a lot that we're learning.
So let me stop for a second. Stop. Because when Dr. Seth Yellin, says it's interrupting our clotting and coagulating abilities, you're somebody who works with clotting and coagulating abilities every day.
Right.
Tell me what you know about that, how you perceive it. You know, I mean, clearly you see certain things in that story that the average person doesn't see. Tell me about clotting and coagulating in your practice and in the history of your medical career.
So obviously, anyone that makes an incision in someone relies on that person's ability to stop their bleeding. We help it along with cauterization, but if you don't have normal platelet function, let's say you take aspirin. Aspirin's a very powerful platelet inactivator. Platelets are basically the finger in the dike. They're the first thing that goes to the injured blood vessel and creates a patch. And then it recruits other chemical processes by sending out signals to further develop that patch into a permanent seal. But without that initial normal platelet function, you're not going to be able to stop the bleeding effectively. The person's going to be at increased risk for postoperative bleeding as well. So in effect, we really deal with disruptions in normal clotting ability, and we even have examples of people that clot too easily. There's a factor V deficiency that makes us more likely to clot. It's an unusual defect, a genetic defect, but I've seen it several times, and these people have a higher risk of clotting and having clots that you don't want postoperatively, like in your legs and lungs and things like that.
You know, when you have a patient come in, do you know beforehand what their clotting or coagulation ability is? Is there a way to assess that?
So there is, but for normal, healthy people, it's very unusual for us to test this. So I will tell you a story. I had a woman, she was in her early to mid 60s, and in just doing my normal assessment with the patient, I asked about past medical history, and she mentioned that she had not one, but 2 bouts of ischemic colitis. Ischemic colitis is like a heart attack of the large bowel, the colon. And that's a rare thing. To have 1 episode is really weird. To have 2 is particularly weird. And I started delving into that. And I asked, did you get fully worked up? Yes, yes, yes. I was worked up by this guy and that guy. I said, were you ever seen by a hematologist? And she said, I don't think so. I said, are you from Northern European extraction? I assumed she was based on the way she appeared. And she said, yes, I am. I said, well, I'd like you to reach out to your internist and be checked for factor V deficiency. And lo and behold, she had that mutation. And she was not ever diagnosed. They never got to the bottom of why she had ischemic colitis twice. I was going to be doing some elective facial surgery on her, but From that, we figured out that her daughter had it. Her daughter was a nurse. Her daughter was on birth control pills and a smoker, both of which are increasing your risk of clotting. So the daughter had her life changed in terms of what she could do and what she could take. And sometimes just being, just following your instincts as a physician and just being a good clinician is really the best way to identify if someone has a clotting deficiency. If someone says, every time I bump myself, I bruise a lot, and sometimes it's pretty significant. And, we're talking about someone that's not very old, someone that might be in their 50s or 60s. You start thinking, well, why is that? Why, other people don't say that. Why do they say that? And then you can start doing your digging. There are many tests you can order, standard tests for different intrinsic and extrinsic systems of our clotting and coagulation systems. You can look at platelet aggregation for clotting. There's things you can do. So the fact is that ultimately it starts like you and I are chatting. It starts just by talking and experience and listening. I think a lot of doctors do more talking than listening. So whenever we're now faced with a new disease that has facets to it that we don't fully understand, we're literally living through this real-time disease description that, usually we're reading about it in textbooks, right? We're able to go back historically and know what to look for. This is novel. That's why it's novel, right? None of us have seen it before. We don't have immunity. We don't understand how it affects us. The way it affects our lungs, it affects the periphery of the lungs. It gives uniform pneumonia rather than isolated or loculated pneumonia in one lobe or one section of a lung. And it's going to the periphery where much of our carbon dioxide and oxygen are exchanged. So it's really creating some significant breathing problems, almost like that in some people. Now the question is why? Well, we're beginning to understand there's some receptors on lung cells. Some people have a mutation. Perhaps those are the people that are at higher risk. Even if they're young, they might be at higher risk. So these things are just being described and discovered right now, day to day. Just turning patients on their stomach has been shown to improve lung capacity. It expands parts of their lung that they're not able to expand when they're lying on their back. If you're obese, it's pushing up your lung. If you're pregnant, it's pushing up your lung. There are times now where they're delivering babies early so that mothers can have more lung function if they're sick with COVID during pregnancy. Interestingly, it doesn't seem to be spreading to children. I've asked several of my colleagues in OBGYN, and it seems to not be crossing the placental barrier. So children, for the most part, are being born healthy, which is great. So, there's a lot we're learning every day about this disease and how it's going to translate into clinical medicine and how it's going to translate into all of us getting out and getting back to life. Hopefully, the more we learn, the more we'll be able to manage, and hopefully we'll have some treatments that can affect quality of life. Now they're talking, I was speaking to an internist friend of mine yesterday, they're thinking about putting all patients who are COVID positive and showing some symptoms, but maybe not severe, on blood thinners, right? So that might be an interesting intervention to try to reduce that small risk of having a stroke or having an infarct or having a cardiac arrest or something like that.
So interesting, because as you start to attack the worst case scenarios, we can all accept a little more risk.
Right. Exactly.
And you mentioned the lung thing. I guess a recent report indicated it was looking into why the sudden downturn for people who were almost symptomless, and then the pneumonia just overtakes them. And I get, you might have seen this report. They found that in a lot of these people, for whatever reason, even though their blood oxygen level is way down, they're not experiencing the normal symptoms of having a very low, VO max?
So their CO2 levels are not climbing as high. They're able to, I may be incorrect on this, but I think they're able to still expel their CO2, but their oxygen exchange is inhibited. So their oxygen blood level is low. And, there's this logarithmic curve for oxygen saturation in the red blood cell. So you're right, you could be right on the edge, and then at like 90%, zoom, it drops and you're in life and death situation very quickly. So I know that they were saying people with very low oxygen, like oxygen even in their, like the 30%, like something that should be killing you, they're like talking on the cell phone, and then all of a sudden, boom, they're dead. Well, I don't think we fully understand what's going on physiologically. Maybe some of the intensivists now with more experience are beginning to get insights. But there's a great example, Michael, of things that we just don't know. This is behaving differently. People look different with this disease than they do with any other disease when it comes to lung function, and how we're able to still exhibit no outward signs of distress, but have these critically low oxygen levels. So, it's no longer my area of expertise, but those who are in the trenches and doing this day to day, I'm sure they're looking into this heavily.
So let me. So I want to ask two things. First of all, before we get off, I want to ask you to help us visualize Dr. Seth Yellin, sort of a day in the life at this moment in time, how, the precautions you take, what you're doing out there, what you and your family are not doing, and then take us into your office and tell us, here's what you can expect from the time you let us know you're here to the time you come into the office at this moment in time. And that might change over the weeks. It probably will change. But I still want to get back to just a little more on your medical career, because just what you told me about putting on the gloves when other people weren't putting on the gloves, it reminded me of a story. One of the foremost experts on hockey is a guy who, I think he's still alive. He's in his 90s. He's written, literally, when I interviewed him a few years ago, he had written 99 books on the NHL. He was one of the New York Rangers' top guys. Fascinating guy. He rode his bike into the interview at CNN Center when I did it. It was about 5 years ago. And
amazing.
And he told me a story of one of the early games he was at before goalies wore face masks. And it's the same thing. It's like there was a time when goalies didn't wear face masks. And he said it was this one goalie refused to go out there without the face mask. And he was pilloried by everybody who said the same thing that your people said, man up. And sure enough, it just took that one person to hold his ground. And then people realized, I don't need to lose my teeth every time a puck.
You and I, when we were kids, goalies were not wearing face masks.
Yeah.
So
your age.
Yeah. So I was in medical school learning to be, a young doctor, and was at Bellevue at NYU. And then after that experience, I decided that for me, I wanted a balance. I wanted a balance between an office practice and a surgical practice. So usually it's the surgical subspecialties that provide that. And those are some of the most competitive residencies to get. And I was fortunate enough to get a great one in New York. So I then chose to do head and neck surgery. Now it's interesting, everyone has like some emotional connection when you're going through medical school. I loved the kidney. I didn't have an emotional connection to the heart. I actually did research at the NIH on kidneys, and I just found, what they did functionally, the way water was moved from inside to outside the cell, to be fascinating. I can't explain why. And likewise with anatomy, I just found the anatomy of the face and the head and the neck to be fascinating. I love the fact that it was so complex, and that our whole identity of who we are, both emotionally in our brains and externally in our faces, it represents who we are. So I just chose to specialize in that arena. But that required 2 years of general surgery and then 4 years of head and neck surgery, And then after that, thinking initially I was going to be doing cancer reconstruction and cancer removal, I then gradually went towards more reconstruction and less removal, and entered into facial plastic surgery, and then did facial plastic surgery fellowship after residency, and then joined Emory as chief of facial plastic surgery in '99. So.
And so stop there, because so first of all, head and neck surgery, and what are the typical, give me a few procedures.
So it's basically ear, nose, throat is the sort of traditional sort of arena, but it's so much more, because the otolaryngologist, head and neck surgeon today does everything from big tumors of the jaw and the tongue and the orbits and everything except the brain, really, to microsurgery of the inner ear, putting in cochlear implants, rebuilding the middle ear, to sinus surgery, to really trauma reconstruction of the mandible and of the face. Everything that is really unrelated to the brain or the eyes themselves. The eyes themselves are the domain of the ophthalmologist. Now, the tissues around the eyes, the lids, the bony orbit, that certainly falls within the otolaryngologist domain, but it's an area that for me is just anatomically complex and just very gratifying, because you're returning someone's quality of life, taste, smell, hearing, speech, all of the things that make us who we are.
So I'm sorry, go ahead. All the things.
Yeah, but also you're returning, if you have to distort them due to some type of removal of something, a cancer, you're returning them to a sense of normalcy physically and emotionally, and that's tremendously important. So that's the area of expertise and interest that I wanted to develop. And I went to Manhattan Eye, Ear, and Throat Hospital, Cornell, which was a sister hospital, Memorial Sloan Kettering Cancer Center. That was all part of my training experience when I was in Manhattan. So I went to NYU, then went to 6 years of training up in the Upper East Side in New York. So I was in Manhattan for 10 years doing medical training. And but my wife and I both are from New York, but we both met at Emory and really fell in love with Atlanta. So we knew ultimately that we'd settle here. Her sister had moved here and started a life. So I went to Florida and worked with one of the great facial plastic surgeons, Dr. Richard Farrier, who was one of the founders of the field, really just one of the godfathers of facial plastic surgery. And spent about a year plus with him, and then came to Atlanta, started practice, was volunteering at Emory and Grady, our city hospital, for several years, and then eventually went full-time and was there from 1999 through 2011, and then left to start Marietta Facial Plastic Surgery Laser and Aesthetic Center, joining actually the largest private dermatology practice in all of Georgia. It's a perfect marriage. What they do and what I do really overlap very nicely. So I do a lot of skin cancer reconstruction, but most of my life today is really about making people feel better. It's really the aesthetic side of medicine. When I was at Emory, I was doing a lot more in terms of functional and reconstruction and clefts and building children new ears who were born without ears and things like that. But today my practice has gotten deep and narrow. But I've really begun to really connect with my patients in a way that I don't think I could have when I was younger, because now I'm older. I'm getting older myself, and I'm seeing the changes on myself and my wife and my friends. And I think, you're beginning to really emotionally connect in a way that I don't think you could in terms of aging and what it does emotionally to us. And, I still have a very robust rhinoplasty practice, but, that I think I've always connected to. But the aging part, I've really been living it, so to speak. So, it's very interesting because none of us like to feel less than. And I think one of the tragedies, I think, of our society in general is that we marginalize older individuals. We're not a society that really elevates and values older individuals and the wisdom that they bring. So, there's a lot of pressure, especially for those that are still in the workforce and getting older, to look young. And I think it's going to be a very challenging time for workers in general. I don't know what businesses will survive. I don't know how much competition there will be, but when you have 20 plus million people unemployed, it's going to really be interesting to see how this economy reawakens and starts again. I was telling my staff the other day in preparation for opening, I said, ultimately, the decision is not ours. Ultimately, the decision are the individuals who come to us. If they want to come, if they feel safe, if they can come, are they emotionally ready to, make that commitment? There's a lot that we don't know. But as a family, my wife is very protective, and we're very fortunate that we're able to stay at home. I have 2 children. They're both New Yorkers. They live in New York as graduate students, and they're both here now. One of them has brought his girlfriend, who's a New York City public school teacher. She's been teaching virtually. I still go to work a little bit. I still have cancer patients to take care of. I still have some other things to do that need getting done. But as the practice opens up, we're going to be adding additional providers. I have 4 estheticians that work for me. I have a physician assistant. I have a nurse practitioner, both of whom practice at my satellite location. So we're not just opening up. We're not doing an instant open. We're doing a very gradual opening. Week 1, adding 1 esthetician, alternating days with me. If I'm in 2 days, she's in 3. If I'm in 3, she's in 2. Then adding a second esthetician, making sure that we can handle the new pattern of practice, figuring out exactly how and where patients' temperatures will be taken, where will they be questioned, probably at the entrance before they enter into the practice itself. We have a full-time person now doing that. So, we have to put systems in place to be mindful and protective. Again, there are people that will get this disease and will do just fine, but you just don't know. So as a medical professional, it's my first obligation to protect everyone. People can make individual decisions on how they want to lead their life, but my job, I've got to make it as safe as I can make it, and then take care of them to the best of my ability. And that's what we're really figuring out right now. So we have policies in place that are basically following the mandates from the government. And then we're looking at best practices. I've been communicating quite frequently with a number of my colleagues. We text often about the techniques that we're going to be using in our own practices, how we're going to be opening. We ask each other questions. It's a great group think, if you would. We're all better and smarter as a group than we are individually. So as you said, this is a time that will teach us a lot. We'll be in flux. We're not Luddites. I don't want to practice in ways that are entrenched. I want to be flexible and nimble and thoughtful and creative. And hopefully the practice will thrive. Hopefully patients will be able to have confidence in coming to the practice. And hopefully other practices and other businesses will learn from each other. Hair salons, it's an important thing to look good, to be confident with your hair, especially for women if they color their hair and they start going gray, and it's a challenging time. And how to protect those patients, and how to protect the cutters, and how to protect the other workers in the environment, in the hair salons. So there's a lot that we're going to be learning. I don't think most restaurants that practice on a thin margin can tolerate half the clients as the maximum number of people in the restaurant and survive. There was a great article today about Gabrielle Hamilton, who runs Prune in New York.
I read that.
Yeah, it's incredibly thoughtful and sad. We're going to lose a lot.
I was so struck by the hours she has put in over years and years without a.
And these are very well known.
It sounds like you've eaten there. I never have.
So she's a well-known chef, and she's a thought leader, and she's just a super interesting person. She wrote a great biography that I encourage you to read as well. It turns out I have a small personal connection. My cousin, who I'm close with here in Atlanta, his son-in-law was one of her sous chefs.
Oh.
Now he runs his own restaurant in Manhattan.
Oh.
So anyway, we're all going to have to figure this out. I was mentioning to my wife today. There's a show on the Food Network, Diners, Drive-Ins, and Dives. And, I was thinking that might become a historical document. Maybe 50% of those restaurants won't survive this crisis. And it's tragic because this adds to the rich tapestry of our society. And without these small mom and pop restaurants, which are built on passion and hard work, we're less rich and less of a society because of that. So, we'll just have to see. I'm sure there are going to be some plastic surgery practices that won't survive this. I will share with you, it's a very tough time for many of my colleagues. And I feel very fortunate that we have such a rock solid practice, and we have really a great group of people. And I appreciate the support that the government has given us. I don't want to dismiss that. The Paycheck Protection Program, the Small Business Association loans, those have been vital to get us through this difficult time and not have to fire people. We can furlough a few. We're keeping a number of people still employed through this crisis, but we have not had to fire anyone. And we've even, as a practice, decided to give some money to our employees above and beyond what they would otherwise earn, just to help them out in this difficult time. So, we've really done everything that we can. None of the partners are benefiting financially at this point. We're really just doing everything we can to keep the business solvent and productive, and we'll get through this crisis and then be able to return. Our practice as a whole is 50 years old this year. And, we were hoping to make this June a celebration of those 50 years. Little did I know we'd be fighting for our practice's life and fighting for the life of so many during this time, but there it is.
It's fascinating. So go back and I'm going to get the transcript, or I might have to send you the raw tape.
Sure.
And maybe get one of your people to transcribe it. But there's so much here that can't come through. And, it can come through ultimately. But it's just very valuable. And also to see, it's like you're somebody I want to come to now because you have this, the way your career went from this big funnel, right? But unlike a funnel, which is like sort of slippery, you've been absorbing, I don't know what the right metaphor is, but absorbing all this, and having the hands-on experience all to this subspecialty where you have this passion and it's in sync with what you're going through in your own life. So, it's like the same heart that you had for the kidney is now, all in this, but even more so because it's the connection between you and all your patients. So I just find it so fascinating. And again, it's one of the reasons I wanted to do it is, one of the reasons I feel like I would send anybody to you.
Thank you, Michael.
Is not just because of my personal experience, but everything leading into my personal experience. So it's all consistent. And now the way, like, I'll tell you, I feel like I would want to check in with you to say, oh, what are your evolving best practices during this time where we have a lot of information and then a lot of questions we don't have answered?
Sure.
I know that if I check in with you, see, this is the thing. If your patients get to hear from you or check in with you once every week or once every couple of weeks, in 2 weeks from now, they're going to learn something from you that you didn't know this week.
True.
But that you learned, and that you're going to figure out, how can I implement this? And then when you communicate it to your text chat group, they're going to come back with other things. There are all these processes, and then we have to ask ourselves, I can really relate to this even on my front, like what am I learning through my unique perspective and access that I can then share with people, and they might be able to use it as actionable intelligence. And then you become this source for like, yeah, I want to make an intentionally be able to connect with Seth Yellin on a somewhat regular basis. Anyway.
I look forward to it, Michael. You know, here's the thing. We're all learning. One of the things that I am so interested in about what you do is you get to sort of lift back the curtain and really delve deeply into individuals who many of us just read about in the newspaper or might see in a bookshelf or, hear their name as an expert in some panel here or there. But you really get to connect with these people. That's a really wonderful, enriching, personally for you, an enriching experience. And then the sort of the learning, I'm sure if you look back on your skills as an interviewer, 10 years ago to now, you would probably have some sort of techniques that you didn't have at your disposal back then that you have now, just from your learning process. But
it's so interesting you said that, because it's not even techniques, as you hear things and process them differently, and you see patterns
right
you can't see if with less experience.
Right.
I mean, I'll just give you this guy David Rohde, who I interviewed yesterday, and Pulitzer Prize winner. He's editor of the New Yorker's online site, and he's been interviewed all over the place about this particular book, and he had just gotten off out of the Amanpour show on CNN, and I just handled the interview differently, but this I would have done years ago too. His new book is really great historical perspective. It's a deep dive into the question of, is there really a deep state? And if there isn't, then what are they talking about? But it's a great historical perspective of 50 years. But I didn't want to start with that book because it's a little too political science-y to start with. But I wanted to go back to the war crimes investigation, and then the captivity, which everybody always asks me. Of course, you want to hear an escape story, but I saw what I thought might be a connection. Very much the way I was talking to you, I'm thinking, well, whatever he's doing in this current book in some way had to have been informed by what he has experienced in his higher risk jobs. In fact, it's very much parallel to you. You had many more higher risk cases. Right. And you can use that protocol, to figure out, how do I approach these cases? But he actually, at the end of the interview, said, a lot of people try to get me to talk about, the captivity. You're the only person who has ever connected the dots between why that was. I was thrilled to hear it, because I didn't even realize I was doing something unique. It was just a process of inquiry. It might have led nowhere. But anyway, but I'm glad to hear you say the peeling back, because this was my obsession when I was at CNN, and even now when I look at any television show or in the newspaper, when they quote an expert, if they would just give me a little more, almost like a living obituary, a little more about why should we trust this person aside from their title, then I can assess for myself. Oh, that's Anyway, the whole thing, it's a similar path in many ways.
It really is. And I will tell you, just speaking to you, you're so thoughtful, you're so insightful, and you're so experienced that I don't have a chance to talk like this to very many people. I mean, we are all, I'm sure, news junkies, right? We're reading all the time, and we're trying to become as informed a citizen as we possibly can. But I also have to remember that I really, day to day, don't affect national policy. I can get upset by it. I would like to have adults leading the country. It would be great. But I do think on a smaller scale that I can have some impact if it's just in my family or just in my practice or just in my community. So having an opportunity to speak with you, first of all, helps me sort of solidify my thoughts, because I'm not really thinking like this day to day, right? I'm not really reflecting the way you're making me reflect. So it's helping me. I'm going to leave this interview and I'm going to think about some of the things that I said and perhaps learn from that alone. And then that'll help me grow.
Well, so maybe there's something for us to do here together. as you proceed, or maybe I can just, for me, it was purely a labor of, love. It's not even a labor. I just wanted to get you saying some of the things that I know you would cover if I made another office visit. And then I feel like, oh my God, those are gems. We have to save those. So now it's all saved. I'm going to click. We're going to finish this recording. You'll have the recording. I don't think I can get somebody, maybe somebody in your office can transcribe, because something, this would be wonderful for any of your, assistants, whether it's the physician's assistant, just to hear. They probably don't even know some of the stuff that.
I think you're right. So I do have a woman, Abby, who does our transcription, and this would be something that I think she can handle. So, I'd like to ultimately have the audio, and then we can maybe clip it and see where that goes.
Well, I'll send you the video link right now.
Oh, good. The video link, great.
It's recorded in the cloud. The Zoom is really, whatever the downsides of Zoom and the problems.
I'm with you. I am with you, man. This is an amazing technology.
It's amazing. But so the final thing I'll say is, because you really, often I interrupt people more than I did with you, because I want to pause at a moment that I feel like we should really slow down. You really do have an amazing ability to take a lot of information, cover a lot of ground, but do it in a measured, linear way. But you're always, it's like you're anticipating my next question. So I just enjoy seeing you. It's like, if I just keep my mouth shut, and you just did it again, you said, maybe you don't have the global or the national policy impact, but just in terms of how you can impact your family and your practice. I was thinking, just however many people are employed in your place are going to go out with more intelligent, safer practices that will then protect them and their concentric circle. This is the whole idea. This is why I call my thing Wave Maker, because it's like, I can't reach in and have, the global impact. Who can? Very few people have the global impact immediately. But if you just have that, impact the people around you, who then impact others,
right.
That's satisfaction in and of itself.
I agree.
Yeah.
Well, I love what you do. Keep it up.
All right.
Look forward to chatting again. And thank you for your time.
I'm going to send you all that. And by the way, I'm going to send you, so we're going to unveil this Nantucket Book Project at the end of this week. And the first guest we have is a woman, Diane Rehm, who has done an NPR show out of Washington for about 30 years, didn't have a college education. And then after about 10 years of parenting, sort of got a volunteer job at WAMU, George Washington's,
Wow.
And then had one of the most popular, shows on the air. And now she's in her 80s, and she's just written a book. She's in great health, and she's written a book on end-of-life decisions, because her husband died of Parkinson's. And in his last days, he wanted to be able to have his life taken humanely, because he couldn't do anything for himself. Right. And because of the law in Maryland, he was not able to do it. And they said, the only thing you can do legally if you want to die is refuse food and water. And he did. And it was a 10-day horrible period. And she has written this book, and it's conversations with a wide variety of people. And you'll appreciate this. One of the things she did in her book, and she has a documentary coming out with it, she wants people to have this conversation. If I should be in a situation where I can't really advocate for myself, or I can, and I just don't want to go on anymore for good reason, here's how I would like it to be ended. So for the last chapter and the last bit of her documentary, she brings in her grandson, who was 18 years old at the time. And she said, push record on your iPhone. I'm going to tell you how it is that I would like the end of my life to be if I should get to the same point as your grandfather. And she told it to him, and it wasn't so scary to listen to. In fact, it was empowering, because it's like, there's a minimal chance that'll happen, but if it does, I want to have some control. And then you can sort of, it's like getting your affairs in order. Now I can go on and just live my life. So I surprised her on the Zoom. This is, again, gets back to what we can do on Zoom. I tracked him down because he's a sophomore. Where did your son go? Dartmouth?
No, he went to Penn.
Did one of them go to Dartmouth?
No, my nephews all go to Dartmouth.
That's right.
Yeah.
This kid, whatever it is, it said on the book, sophomore, Dartmouth. And I said, I'm going to look him up. And then I look him up, and he's got a research. He's studying, like your son, neuroscience. Wasn't your son doing that?
No, my son wasn't, but my son's in math, and then I have another one in business.
Yeah, but maybe it was your nephew who I was talking to about neuroscience. I can't remember now, but so this kid is studying neuroscience, and then I see he's got an internship with an Alzheimer's researcher. So I'm thinking, oh, maybe his grandmother and his grandfather's experience. And sure enough, I called him. I said, and he was the most wonderful, intelligent young guy. I said, how would you like to surprise your grandmother during this interview? Would she like it? He said, oh, yeah. They have a very close relationship. So I had her read the passage that she read to her grandson. And then I said,
great.
I'd like to bring in somebody who really should be in this conversation now. And I texted him, he clicked the link and he pops up. But the reason I mentioned that to you is, again, it's one of those things you don't have a reason to talk to your patients about that. But I'll tell you something, starting a conversation about that. And I told her, I said, you know what, you enabled me to start a conversation with myself about it. And it really did. I started, how would I articulate that?
So, we are kinder to our pets than we are to our partners, right? If your pet is suffering, like I had to put one of my pets down. He developed an inability to walk. He developed an inability to be continent. It all happened like that. And he was in terrible pain. He was crying out in pain. I mean, it was an easy decision. Within 12 hours, I put him out of his misery. If all of a sudden that was me and I had no ability to recover at all, that's not a quality of life. To be in terrible screaming pain, unable to walk, unable to be continent, it's untenable. So I think we are in many ways kinder to our animals than we are to ourselves. And it comes back to the Bible, and there's religious overtones about not taking one's own life and all of those sorts of things. But I think Oregon has a
right.
Compassionate end of life thing that the electorate has passed. And I know Switzerland has that. We have a friend that has some really bad medical condition, and she's arranged, to have end of life handled, which allows her to live her life free of the fear that she would end up being so terminally ill with all these terrible pains and things that she couldn't function. So I think it's empowered her to live. One thing, we are the only species that I believe has the burden and the gift of living our whole lives knowing that one day we will die. So knowing that, it's not like you're preventing something from happening. You're just preventing it. If you kill yourself for depression or something that's treatable, that's a tragedy. But if you have no treatments and you're in terrible pain and you're unable to move and you're frozen, like from Parkinson's, at what point do you say it's inhumane to keep this person alive, right? So, I come down on the side of, I want control of the end of my life. Right. I don't want to be someone who, God forbid, is a vegetable or has no function whatsoever. Listen, I know there are exceptions. Stephen Hawking, the guy is just, incredible on so many levels, but he lived to 70 or so in that debilitated state. I don't know if I would have been as brave. That's a pretty brave man right there. But it's a fascinating thing that you had the opportunity to speak with this woman. I've heard of this woman. I remember I've probably listened to her a few times on
You'll recognize her voice, and actually you'll be fascinated because there's a head and neck story there. I won't give away the whole story. I want you to watch her, but and see what I did with her. But she did early in her career, she had this nerve issue with her vocal cords that made her sound shaky. And she thought that was the end of her career, and her station manager stood up for her. And when they got calls from the audience complaining, the station manager, she told me, defended her and said, just listen to the content. And in the end, her voice worked to her advantage. but she gets
I know
Botox.
exactly who she is. I listened to her, and I remember
Yeah.
her final show actually.
Yeah.
I will. Yeah, I'll tell you. You said that it doesn't come into play in my world. I had a patient that came to me. I had been her doctor for about 10 years, and she shared with me that she had terminal cancer. And in fact, it was the same cancer that took my father's life. And I knew that the end was near. She had a moment of reprieve where she was responding to some treatments, but that was short lived. And then eventually she recognized that her time was very short. And she came and she wanted me to do some aesthetic injections in her face. And I tactfully sort of brought up the conversation as to what her motivation was. And she said to me, I really want to look good in my casket. And that's the way she wanted to be remembered. And if you don't think what I do has some deep emotional impact, you just have to hear that story. And I have to tell you, I was crying through the entire injection. I had tears in my eyes. So, sometimes even in the least expected places, we do have to deal with end-of-life issues. We are physicians.
That's an incredible story. I'm glad I was still rolling on that story. I have to say, that's an incredible story. And you know what? If my mother were alive, I would send her to you. And because she was so terrified of most doctors, she was crazy with doctors. Like because she didn't want to find out anything bad. So she was neurotic about that. Where her best friend would have to make the appointment, and my mother didn't drive because she always lived in the city. My best friend would come for their afternoon drive or whatever, and would say, "Okay, we're going to the doctor today. It's your appointment," and would surprise. But my mother would have loved to have taken care of a lot of stuff, including for the casket. She wouldn't have wanted to talk about that, but definitely, I can totally relate to that. But
all right, buddy. I just want to say thank you.
Yeah, thank you. And it's beyond this. It was great talking to you. I got to talk to you for an hour and a half. This was fantastic.
It was. It really was. You look well. Stay well. Regards home.
Thank you.
Take care.
Talk to you later. Bye-bye.